What do we do when Ozempic fails? First of all, if you and your medical team are actively working together on trying to get this obesity disease under control, congrats for being in the game. Second, if the meds aren't working, if you're on the first med or the second med, or if they did work and now they don't, I hope there won't be a guilt conversation with that. And also, I hope that you won't quit. The obesity disease is tough, and we have to keep moving forward and altering, updating our treatment plan to get the best long-term health. Now, when I say don't quit, I don't mean that you keep doing the same thing over and over again. I just mean that you stay with your team and circle back and consider other options, which I'm going to come back to, all with the idea that you deserve better health. My name is John Pilcher. I'm a bariatric surgeon in San Antonio. And if you're new to this conversation about GLP medicines, that would be pretty surprising, actually. But just to be on the safe side, what we're talking about are two injectable medicines in this class. The first is called semaglutide, which is sold as Ozempic for diabetes and Wegovy for weight loss. And the second one is tirzepatide, which is sold as Zepbound. It's sold as Mounjaro for diabetes and Zepbound for weight loss. In the next few years, there'll be many more meds in this general class. I think the overall effects are going to be similar, although I'll have some updated videos. Now, these are really significant new tools that fill a much needed role for middle intensity treatment of the obesity disease, and I believe they should be employed much more widely than is currently done. I believe that over the next few years, these meds will be much more widely used, and we'll work through the cost barriers and what have unfortunately been prejudice barriers for use as well. Overall, wide acceptance of obesity as a disease over the old idea of obesity as a choice should lead to better engagement of the disease at earlier stages, and earlier engagement should lead to better outcomes. And let's talk about this. Treatment with GLP meds can be amazing. Not only does it feel better to be at a lower weight, but the GLPs can give patients a sensation of being in control of their bodies for the first time in years. That hunger monkey stops jumping around in the back of your skull and the food noise kind of shuts up. What a relief. While we're really excited and hopeful about these new options for obesity disease treatment, we have to digest a few sobering facts and concepts. First of all, our society up against this obesity disease is way behind the power curve. Up until recently, the main strategy for managing this obesity disease has been denial. There's been denial that it's a medical problem and denial that it's a society problem. Denial has meant that we're only beginning to get serious about treating this condition, and it means that many millions of Americans are already suffering from advanced and hazardous and life-changing, life-threatening obesity disease. The second challenge is that obesity is a lifetime disease. In other words, there's not going to be a simple or a time-limited treatment that will get people to the lifetime health that they deserve in a definitive, final way. It's going to take ongoing management. The third part of this challenge is that advanced stage obesity disease can be hard to treat, and many current cases are beyond the power or the impact of medicine alone. We're going to need synergistic multimodal therapy. And these challenges are the reason that we even need to have a conversation about what to do when meds fall short. To be perfectly clear, I'm a fan of every effective weight loss intervention. I don't think we should have conversations about using lifestyle or medicines or surgery. I think we should have conversations about combining these therapies as fits the individual patient, potentially lifestyle and meds and surgery, or lifestyle and surgery, or lifestyle and meds, or then meds after surgery. All those things should be options. If our medical system worked really well, patients would have their obesity disease treated at an early stage, like I mentioned a minute ago, and many could be successful with lifestyle management alone because they're at an early stage. Or maybe lifestyle plus medicines. Some patients might still need surgery, but only after several years of obesity treatment, if or when the less intense options were unsuccessful. But that's a fantasy world. Returning to the actual situation here in 2025, medication treatment can fail in several ways. Or maybe we should use some of the terms that we get from cancer treatment. Maybe we shouldn't say that the medications fail, but we should say that this person's obesity disease didn't respond fully or was a partial responder to that particular treatment. And there are several ways that GLPs and similar meds can fail in the face of advanced stage obesity disease, okay? First of all, there can be affordability problems with meds, either starting the meds, getting access through the insurance process, or in continuing the meds in terms of copays, etc. Remember, the meds don't fix the obesity disease and then become unnecessary. If they're going to be part of the treatment plan, it's going to be important for them to be taken forever to have an impact. There also can be supply problems with these medicines. Now, I'm certain that the availability issues with the GLP medicines are going to get worked out, and I think the cost issues will improve as well. I think insurance coverage will become more available, and that the manufacturers will drop their costs as other medicines become available. So let's say that those aren't going to be long-term modes of failure for the GLP medicines. I think there are still going to be several other areas where they could fall short. The first of these on a medical basis is that a person may just not be able to handle the medicines, or there may be some physical, we say, contraindication, some reason that the medicine should not be taken. So side effects, either awareness of potential side effects or actual side effects when the meds are tried. The second thing is that even if the meds are used appropriately and timely, there may be failure of sufficient weight loss or failure to see sufficient improvement in the medical conditions that we're trying to treat using these medicines for weight loss. This is more likely if a patient waits until the disease is advanced before starting treatment. Unfortunately, that's what we're used to right now. And unfortunately, that's been the common practice so far. The third thing is that there may be initial success with the medicines, but there may be reoccurrence of weight problems or disease after initial success. And this can happen because of normal progression or worsening of the obesity disease, or because the body becomes accustomed to the meds that are being used. One option when the medications fail is to add medicines or try some different medicines, and I think that these medication options are definitely going to expand with the progression of the pharmacologic pipeline. And that's great for patients. Another option, of course, I'm a bariatric surgeon, is to think about surgical treatment with or without medicines, of course, still based on lifestyle. And surgical treatment has been the mainstay and the most reliable means of obesity treatment for a few decades. Surgical treatment is still more potent than meds by a pretty significant degree. Now we can see from this bar graph that describes the weight loss percentages with different treatment plans how things shake out. First of all, notice that lifestyle treatment alone leads to about 5% weight loss, and that the GLP meds are clearly better than lifestyle alone, and that gastric sleeve or gastric bypass lead to significantly more weight loss than the modern weight loss meds, which are Wegovy and Zepbound. Interestingly, this graph is based on statistics from the FDA research trials, and there is pretty significant early data showing that in the real world, in the wild, the GLP medicines are about half as effective as I presented on that graph. Patients and policymakers should also be aware that surgery turns out to be a lot less expensive than GLP medicines, at least in the current environment. Check out this graph. It's no surprise to see that the surgical trend line in blue has a bigger jump at first due to surgery and the associated costs around surgery. Then the surgical costs are relatively small on a yearly basis, while the meds with the orange line have almost the same cost year after year. At the time I'm recording this, most patients, and the ones who pay their bills like employers, find that surgery costs less than GLP medicines between 2 and 3 years as the crossover. Choosing a surgical option shouldn't mean that meds are never used. Most of us who work in this field believe that the best plan is individualized to each patient's situation, and many with advanced obesity disease can benefit from combination therapy with medicines and surgery together, using the treatment that's going to be the most safe and sustainable in the long run. Patients need the right treatment at the right time. I like to conceptualize this idea of combination therapy and the right treatment at the right time and long-term and integrated using this obesity treatment pyramid. Everything in the pyramid is based on lifestyle optimization as a foundation. Depending on the patient's situation, they may add medication or perhaps even jump from lifestyle intervention past medication into surgery and then perhaps circle back to medication or not. But notice the key thing is that I talked about lifetime management. So in my view, patients should stay with this pyramid. Whatever treatment they've had, they should regularly circle back for updated staging and an updated treatment plan. All these levels should be continuously available to optimize the overall management and the lifetime success with health outcomes. Here are my key points. If you start treatment at an early stage, you have a better chance of a long and healthy life. These days, a lot of people already have advanced obesity disease when they first get treated for this problem. It's no surprise and no fault of the meds if the meds fail to be fully therapeutic in this kind of challenging situation. Most people with the obesity disease will need their treatment to be updated and modified over the years. We don't know of anything that cures the obesity disease, we just have realistic goals of keeping it under control in the long run. And you're likely to do best with a specialist team of providers who do obesity disease as their full-time job. This is a rapidly developing field, and it takes focus for providers to stay up to date and to recommend the best personalized therapy. All that being said, I hope you'll get seen and get treated. I wish you the best of luck on your journey.